This Week in Virology, the podcast about viruses, the kind that make you sick. From Microbe TV, this is TWiV, This Week in Virology, episode 1184, recorded on January 16, 2025. I'm Vincent Racaniello. You're listening to the podcast all about viruses. Joining me today from New York, Daniel Griffin.
Hello, everyone.
What's on the tie, Daniel? It's too dark for me to make out.
It is covered with C. difficile.
C. diff. Not good.
Yeah, no, not good. You know, we seem to be doing a little bit better with C. diff, interesting enough. But yeah, not a great thing. One of the things we hate to have to deal with in the healthcare setting. So, but we got a lot to talk about today, Vincent. So I'm going to jump right in, and I'm going to start with a Longfellow quotation. I was reading a bit of poetry the last day or so, which apparently I tend to do, and I ran across this quotation. Perseverance is a great element of success. If you only knock long enough and loud enough at the gate, you are sure to wake up somebody. How does that ring any bells for you there, Vincent? Do you feel like you're knocking long and loud enough?
I try.
Okay, don't stop knocking. I guess that's the message there. Just keep. So we have a few things to talk about, and so maybe this is a knocking at the gate themed episode. But the first is a very sobering article for dry January. Even adults may soon be vulnerable to childhood diseases, written by Apoorva Mandavili, published in the New York Times. And I encourage our listeners to read, or I think you can listen to articles now. So just a few highlights, but go spend some time. And here I'm going to a few quotations. There were more than 32,000 cases of whooping, however you want to pronounce that, cough in 2024, the highest tally in a decade. In California alone, the disease struck 2,000 people between January and October last year. More than 60 infants younger than 4 months were hospitalized in the state. One died. Very compelling is the discussion of how quickly things can unravel. I think this is, for those thinking, things are going to maybe change, but don't worry, it'll take a long time before the something comes back to roost. There's some expression there. But here was something that I read in this article. In the late 1980s, budget cuts by the Reagan administration brought down vaccination rates, particularly among low-income Black and Hispanic children. The fallout was swift. From 1989 through 1991, measles infected more than 55,000 Americans and killed 166. So things can unravel pretty quickly. And we're going to go right into polio vaccination. There's another article also by Apoorva Mandavili, how lagging vaccination could lead to a polio resurgence, also in the New York Times. And so I'm going to read a section, and then Vincent and I can discuss. So here's the section I'll start with. There are 3 types of I want you to criticize this, Vince, and you can put on your criticism hat. But
okay.
So there are 3 types of polio viruses, and eradication requires that all 3 disappear. For years, the goal has been tantalizingly close. Type 2 was declared vanquished in 2015, and type 3 in 2019. Type 1 now circulates only in Afghanistan and Pakistan. In 2021, the 2 countries together had just 5 cases. In 2024, they had 93. Goes on to write, but these figures tell only part of the story. In a surprising twist, an oral vaccine used in some parts of the world has kept poliovirus circulating long after it should have died out. And then Apoorva writes, the problem is this. Since 2016, the oral vaccine used for routine immunization has not protected against type 2 virus. Global health authorities made a deliberate decision to reformulate the vaccine on the grounds that naturally occurring type 2 virus had disappeared. That turned out to be premature. More type 2 virus has been shed by orally vaccinated children in some parts of the world than officials had anticipated. When some non-immunized children or those given the newer oral vaccine encountered this vaccine-derived type 2 virus, they became infected and paralyzed. Vaccine-derived poliovirus now paralyzes more children than naturally occurring virus does. For example, Nigeria eliminated all so-called wild-type polio in 2020, but in 2024, the country saw 93 cases of type 2 vaccine-derived virus, more than one-third the global total. Now, none of this is a problem in Americans as long as they are vaccinated. The inactivated polio vaccine, IPV, used for routine immunization of American children, protects against all three types of polio. These formulations contain dead virus and so cannot cause disease or revert to a dangerous form. What are your thoughts, Vincent?
So the first sentence, there are three types of polioviruses and eradication requires that all three disappear. No, you cannot make viruses disappear. You can try to eradicate poliomyelitis, which is the disease. And as she writes, types 2 and 3 poliomyelitis have been eradicated. But type 2 is the problem. And you can never, ever eradicate poliovirus because as long as the world is using OPV, you're still putting infectious viruses out there. And type 2 OPV is a real problem. There have been many, many thousands of cases since 2016 when the type 2 component was withdrawn from the vaccine, which was a big mistake by WHO and CDC. Now, a lot of the world uses IPV, including the US and much of Europe. That's great because it prevents poliomyelitis. It doesn't cause polio. The rest of the world should switch as well, but we're going to have to use that forever. There will be no stopping vaccination with IPV because the virus will continue to circulate. Even if you stop using OPV, which the WHO wants to do in 5 to 10 years, those viruses will still circulate because the intestines of people immunized with IPV are still infectable. And that's why the virus has been found in Europe, in Australia. It's even here in the U.S. in environmental samples.
Yeah, I think these are important points. Maybe she should have called you Vincent, but I don't know. I don't know how well you get along with. Oh, she did.
She did. But some things still are not right.
Okay, you should have asked for a read at the end, but yeah,
they don't like when you do that. They hate that. Yeah.
Really, Apoorva's usually good because I think she has a high standard for her work, and I think
she talked to me a couple of times.
Yeah,
and also someone else who was very knowledgeable, but you can only absorb so much, I think, and
yeah. And it's hard too. I mean, so I think these are important points to supplement her article. One is that there is this important disease this important distinction we keep hammering in, the distinction between polio virus and poliomyelitis, the disease. Maybe we did okay with SARS-CoV-2 and COVID-19 because we have two different names, right?
Yeah, people still complained about it,
Yeah, we complained when it happened, but maybe, in retrospect, right? So, one is that confusion. So it's important to make the distinction. The other is, as long as we keep giving people oral type 2 polio virus vaccine, we are introducing this virus into the environment. And it reverts in people and then they shed it. So we keep putting it into the environment. IPV cannot end up in the environment. It's not replication competent, only, upside to all that. So we really need to move away from this oral vaccine, which as we've talked about, this is not the way Sabin wanted this used, these spotty little campaigns where you introduce it into an area. And all right. I think that I would love, as we keep talking about, if we in our reports could talk about levels of vaccine-derived poliovirus in water here in the U.S. so people would realize polio's here. And you really need to keep moving forward with inactivated polio vaccine, because none of this is a problem in Americans. Well, it is a problem because we're having vaccination rates drop. We had that boy get paralyzed a couple summers ago, just here in New York State, because people don't appreciate that polio virus is here. All right. Norovirus. So norovirus, got a lot of interest in norovirus. So I'm going to talk about a fun article, and then we're even going to spend a little time on norovirus. Maybe while there's still a TikTok, this will be cut out as a TikTok norovirus update, Vincent. But a fun article, and I love the title. Why the Ferrari of viruses is surging through the Northern Hemisphere, published in Science. So
why is it a Ferrari? Is it really expensive?
Well, let's see. Why do they call it? Why do they call it the Ferrari of viruses? Well, you'll find this entertaining. So the quote unquote Ferrari of viruses is having a banner season. Norovirus, which races through cruise ships, homes, and long-term facilities, is experiencing a remarkable winter surge in the Northern Hemisphere, sending large numbers of people racing to the bathroom, like a Ferrari, I guess, and many others to the hospital, and in rare cases, proving fatal. In the United States, for example, 91 outbreaks of the intestinal virus occurred in the first week of December 2024, far above the previous maximum, the previous record of 65 for the same week between 2010 and 2024. And levels of the genes, I like that, right? Because this is wastewater nucleic acid detection. Levels of its genes in U.S. wastewater are now an order of magnitude, a log above last year. And I will say I did return from vacation to tales of many sick colleagues and a number of folks in the hospital with winter vomiting disease. Winter vomiting disease. So Albert Kapakian at the U.S. NIH discovered, now in this article, they say discovered the first norovirus in 1972 from an outbreak of winter vomiting disease that occurred at an elementary school in Norwalk, Ohio, hence the Noro in the name. But scientists have since described more than 30 major variants that circulate in humans, distinguished by changes in their surface protein VP1, which is the main target of antibodies that can neutralize.
In fact, it was once called Norwalk virus, but the people in Norwalk didn't like that.
I remember that's how I was first taught, that it was Norwalk virus. And they have this great, this great figure where you can actually it's huge, the levels of the norovirus concentration in
Daniel, water. The title of this article is Why the Ferrari is Surging. Nowhere in this article do they explain why it's surging. They say it is surging, but why?
All right, so let's talk about norovirus. Let's talk about why it's surging and racing through our population. So this, first I will point out, as they point out, that norovirus wastewater levels are high. It's one of the 5 that are high. We talk about all the ones that are high, right? So flu A is high, COVID, SARS-CoV-2, the virus is high. RSV is high. Norovirus is high. So let's talk a little bit. So background, yes, nicknamed winter vomiting disease due to its seasonal predilection and preponderance of patients with vomiting as a primary symptom. And actually the name preceded the recognition of the virus, right? So it was named back in 1929 by this Dr. Zahorsky. And then in 1968, there are 2 epidemics that are investigated. And at this point, it's interesting. I was going through and rereading these articles. They're not sure what it is. They think it's viral. And then in 1971, there's this great publication, I'll leave a link to it, where they identify these 27 nanometer particles, and they even do challenge studies on volunteers. You ready for this? So no one can culture this virus until 2016. So what they're actually doing is they're using stool filtrates, and they're giving stool filtrates to these volunteers. And then after an incubation period of 24 to 48 hours, these heroes of infectious disease are now vomiting, sick,
But you know, Daniel, they add a little flavoring so it doesn't taste so bad.
Oh my God. Can you imagine this? Us, we want you to sign up. We're going to pay you, I don't know, some amount of money. Who knows if they paid people back then? And then there's a norovirus shedding maximum at 24 to 48 hours after illness onset. So they're vomiting, the horrible diarrhea, but people continue to shed virus for up to 4 weeks. I mean, this is hardy stuff. And here's actually spread of norovirus can occur via infectious droplets when a person vomits, right? So we were talking last night as we're recording ID Puscast about here you are, you're on the subway, and they've now got these subways that are completely connected, right? There aren't like doors between the trains. And so someone with norovirus vomits, they can actually produce this aerosol of infectious virus. And, you think it's bad on a subway, but on a cruise ship, right? They've got these ventilation systems that suck the air out of your room and then blast it into someone else's room. So you can actually suck norovirus from that room where someone is vomiting and basically spread it throughout the entire cruise ship, right?
Also happens on airplanes.
Yeah, someone with norovirus on an airplane starts vomiting, and what are you doing? You're like, it's all in the air. It gets on stuff, so you can touch stuff. You can get it from eating contaminated food or water. People get it from oysters, right? I mean, I don't know why anyone eats oysters, vegetables, fruits. And the classic is the handshake. I was involved in the investigation of a norovirus outbreak where it was the maitre d'. And we were able to figure out everyone who shook the hand of the maitre d' was vomiting, 2 to 3 days later. Not funny. I know it's not funny. Well, I've had norovirus myself, so I know it's not funny.
But Daniel.
Yes.
All of this doesn't explain why it's surging this season.
Yeah. Why is it surging? So in the article, they talk a little bit about, we've now come out of this post-COVID lockdown and the number of gatherings, the number of get-togethers. So we really have had this surge of people getting together and coinciding with enough norovirus in the environment so that people are going to these gatherings. So when we talk about these outbreaks, 90 outbreaks, that's exactly what it is. There's some kind of an event. You get the people together, and then you have just dozens of cases of people getting sick.
So you're saying people are getting together more often because they're happy to be out of the pandemic, and that's it.
I think that's a lot of it. But there's also the other, and this is I call it the Chipotle story, is people have started using hand sanitizer. I don't know if you've noticed, like people sometimes even have it like clipped to their bag. Like
yeah, sure.
They shake your hand and then they think, oh, just lather up, nice thick thing of this alcohol-based cleanser. It doesn't work. You've got to actually use soap and water. And that's another thing that we've seen over time is that people are relying on these alcohol-based hand sanitizers and they're not using the soap and water. And it's critical, right? We have a bunch of people in the hospital with this. And where are the sinks, right? And so what you really got to do is every time you see someone, you got to be washing those hands before you start picking up food and hors d'oeuvres, right? The perfect setting, right, is one of these parties, right? I was at a party this week, and they walk around with the trays and you with your hand, but you just shook someone's hand. And did you go in soap and water before you started putting? And it only takes, it takes less than 100 viral particles, maybe 15 or 20 required for transmission. So a tiny inoculum.
Ian Lipkin stopped shaking hands, and he says it's decreased his rate of infections.
I like that.
He just does a fist bump, brief contact.
Yeah, the fist bump, maybe the, tap of the elbow. Yeah, you don't really need to get in there with that hand.
Especially you, Daniel, as a physician. You shouldn't be shaking your hands of everybody that you see. You see hundreds of people a day, right?
It is amazing how much I wash my hands, I have to say. And sometimes I feel like, I think there was that show Monk where the guy like shakes someone's hand immediately. He's doing the, and sometimes I'm like, am I going to like offend people? But yeah, I was gone last week on vacation. One of my partners supposed to be covering, she's home vomiting. This is really, This is tough. And it is tough because the alcohol is so quick and easy between patients. But yeah, if you're worried about winter vomiting disease, these viruses without an envelope, you really got to get in there with the soap and the water. All right. Any other comments on winter vomiting disease, Vincent?
So the idea is that the increased use of hand sanitizer coupled with more parties is responsible for the increase.
And actually, there is an article, I'll leave a link to it, which is this article showing that alcohol-based hand sanitizer may actually be associated with an increase in norovirus transmission. So, Yep. And on those cruise ships, right? Wasn't that their first measure? Like, oh, we'll just go ahead and have more alcohol and hand sanitizer. It's just
now they have. There's a cruise ship director in Norway who writes to TWiV, and he said now they have all these fancy hand washing stations where you put your hands in 2 holes and they wash and dry them for you.
In one of our hospitals, they have that. You roll up the sleeves and your arms go in right up to the elbows, and it does kind of the whole thing, and then out come your maybe clean hands. Yeah. So, all right. Pneumonia and vaccines. This is our public service announcement in the form of the MMWR, expanded recommendations for use of pneumococcal conjugate vaccines among adults aged 50 and over. Recommendations of the Advisory Committee on Immunization Practices, United States 2024. And just back in October 23rd, 2024, the ACIP recommended a single dose of pneumococcal conjugate vaccine. So that's the PCV for all adults 50 and over. And this is for people who, are not vaccinated or you're not sure about their vaccination history. No issue if you get a second dose. There are high-risk folks who are younger and, keep following those recommendations. And what are our choices? You really have 2 choices. So the 20-valent PCV20 or Prevnar 20, or the 21-valent PCV or PCV21, Capvaxive. So anyone 50 and over, myself included, go out and get your shot.
How often should you get this?
This is a once in a lifetime.
Okay.
All right. And avian influenza. I've been following this. I wasn't able to get any more updates recently, but there's a child. San Francisco Department of Health announced a presumptive H5N1 avian flu infection in a child with fever and conjunctivitis, San Francisco. Really not much updated there. Sort of with the symptomatology making me think of type B, right?
Bovine. Type B for bovine, right?
B for bovine, and hopefully B for benign in this case. And more cats are dying from eating the raw cat food. So, by the way. All right, flu, influenza A. We are still at very, very high level. Actually, this is our big respiratory pathogen at the moment. And you can, if you look at maps across the country, we're at high levels through most of the country, except Montana and Wyoming. I'm not sure what's going on up there, but good stuff there. But if you look, and COVID-19, influenza, RSV, maybe 1% or so of the ER visits are due to COVID and RSV. But influenza, that's up there at 5+%. So that's our big, and we're peaking. It looks like a very similar peak to January of 2024. So hopefully it's going to get better. But that brings me to this wonderful article, and I'm going to theme this discussion. Why don't we use more Xofluza? And so I know one of our listeners, will enjoy this, I hope. The article, Antiviral Medications for Treatment of Non-Severe Influenza, a systematic review and network meta-analysis published in JAMA Internal Medicine. So they do this search where they're searching all these databases. They say search from database inception to September 20th, 23. I'm going to start adding that. I should have added that to our recent paper, Vincent, right? Because that's actually kind of what you do. You don't really put don't give me those old articles. You may not get to all the ones when you go through your list, but they search database inception up to September 20th, 2023. and the selected randomized clinical trials comparing direct-acting influenza antiviral drugs to placebo, what they refer to as standard of care, other antiviral drugs. And they're going to look at mortality, admission to hospital, admission to the ICU, duration of hospitalization, time to alleviation of symptoms, emergence of resistance, and adverse events. So overall, they've got 73 trials, 34,332 participants included. And they're going to basically tell us that compared with standard care or placebo, all antiviral drugs had little or no effect on mortality for low-risk patients. And they're going to say, and high-risk patients. Now, I'm going to break this down a little. So for hospital admission in high-risk patients, oseltamivir, little or no effect, but baloxavir, Xofluza, may have reduced the risk. All other drugs may have had little or uncertain effect. For time to alleviation of symptoms, baloxavir probably reduced symptom duration, maybe by about a day. Tamiflu, oseltamivir, probably had no important effect. Now, for adverse events, baloxavir, few or none, but actually Tamiflu, oseltamivir probably increased adverse events. So they're going to summarize this by saying baloxavir, Xofluza, likely reduces time to alleviation of symptoms by about a day, does not increase adverse events related to treatment, but may be associated with emergence of resistance in approximately 10% of those treated. And Tamiflu, oseltamivir, was found to have little or no effect on mortality, admission to hospital, like no important effect on time to alleviation of symptoms, likely increases risk of adverse events related to treatment. But I got some comments.
Yeah, is this surprising to you, Daniel?
Well, what I think it's a problematic publication. And the reason I say that is that if you go through those 73 trials, what you really need to do is throw out the trials where they didn't start treatment within the first 48 hours.
Mm-hmm.
Right? Because otherwise what they do is they're diluting the studies.
Yep.
And so if you go through the actual individual studies and you look at ones where you could see that the Tamiflu was started within 48 hours, you're seeing a benefit. But once you get out to day 5, it's useless. And so I think that should really be the takeaway. And that's the problem with some of these systematic reviews and meta-analysis is you can dilute out good studies with bad studies.
What did Mark Crislip used to say?
If you pile the cow pies high, they do not turn into gold. But that's what people hope with a meta-analysis, right? Just got all these studies and, all this statistical power, but you throw enough bad studies in there and it gets rid of it. So,
okay, so
yes,
a lot of people are going to look at this and say, see, the antivirals are useless, but that's not the case.
I think and that's what I worry about. And those are the headlines, right?
Yeah.
The headlines of these are useless. But the headline should be, if you're going to do an antiviral, you need to get in there quickly, right? So you really want to get in there within 48 hours. So that's number one. The other is that Xofluza is probably underutilized, right? It's a good drug. And it's probably about the same course. But there's a problem with Xofluza, Vincent. And there's two problems with Xofluza. One is bad marketing by, I think, Shinogi. The other is it's only one pill. And so the problem is I call it the Z-Pack phenomenon, is that by the time you call the doctor and say, I'm not feeling well, if they can give you something like a Z-Pack over 5 days, by the time you finish those 5 days, it's the phenomenon where if you don't do anything, you're going to be sick for 7 days. But if you take a Z-Pack, you're better within a week.
Oh, yeah, that's great.
Right. And so the problem with the Xofluza is you're going to take that one pill and 2 days later, you're still sick. Where the Tamiflu, you take it for 5 days and by the time you finish, you're feeling better. So the experience, the art of medicine is thwarted by a one-tablet solution.
Maybe they should be over the counter, Daniel, so you could just go get them.
I think, so that's one of the problems with the delay. By the time you schedule the doctor, by the time you get your treatment, and that was that great program we had with the Medicare Advantage folks where they would call, they would have the ability to do an at-home test, and then they would have a little Bluetooth box and you put in the code, it would open, they'd start the Tamiflu, early on within the first 24 hours. And that's how you get people better, not putting all these roadblocks and delays in the
Many
way.
people in many countries in the world, this is over-the-counter stuff, right?
It would make sense to me. Yeah. All right, RSV and the numbers are actually shooting up, right? So we're seeing, if you look at the pattern for RSV, we're at a very high level, and we're really seeing it's kind of similar, right? It was November of last year when things started to shoot up, peaking in about January. So we may be right about the peak of RSV for the season. It looks like the peak may be a little lower if that trend holds. So. But yeah, number of folks in the hospital with RSV, so that's tough. All right, and COVID, SARS-CoV-2 viral wastewater levels continue to be high, and unfortunately, we're starting to see that lagging indicator of deaths in a number of our states, so Wisconsin, Pennsylvania, Ohio, Indiana, and looking at the wastewater, right? We are still on the way up all the way across the country. So as flu may be coming down, COVID is moving right in to take its place. All right. And what do we do about it? Remember, testing, right? Apparently the prices of some of those tests are coming down, which is great. And that really, I have to say, from a patient perspective, that's the way to approach this. If you're worried about COVID, you're worried about flu, go ahead, do those tests. And if you're positive, call your provider. And as per NIH and IDSA guidelines, number one, Paxlovid, still about an 80% reduction in progression, even if you're vaccinated, even if you're boosted. We have remdesivir as an option, molnupiravir, convalescent plasma. And then unfortunately, we are still having some folks progress to the early inflammatory phase, where steroids, pulmonary support, anticoagulation, remdesivir, and immune modulation can have a role. All right, and to wrap us up with an article here, really two articles in our long COVID post-acute sequelae. First, the article, Symptom Evolution in Individuals with Ongoing Symptomatic COVID-19 and Post-COVID-19 Syndrome After SARS-CoV-2 Vaccination versus Influenza Vaccination, published in the Journal of Infection. So, background, COVID-19 symptoms may persist beyond acute SARS-CoV-2 infection as ongoing symptomatic COVID-19 and post-COVID syndrome. You can actually see this go out 4 to 12. That's kind of our medium COVID and our PCS greater than 12 weeks. So here they're going to use the Zoe COVID symptom study app, and they're going to do two comparative analyses. Both are prospective. So they're doing this prospective reporting in individuals who either have that OCS, so that ongoing symptomatic COVID, medium COVID, or PCS, that's that greater than 12-week or long COVID. And they're going to look at symptoms in individuals receiving vaccination compared with unvaccinated individuals. They're going to do a whole bunch of matching there. And then they're also going to look at symptoms in individuals receiving vaccination against influenza compared to unvaccinated. And in both analyses, they're going to look at vaccination date. And what do they find? After first vaccination against SARS-CoV-2, many symptoms in individuals with medium or long COVID improved more rapidly than natural history resolution, including the commonly reported symptom of fatigue. That's with pretty good value. Also, myalgia with good p-values, no symptom worsening after vaccination in this study. In contrast, getting a flu shot did not help with medium or long COVID, not surprising. Some nice figures. The conclusions and the p-values may be a little more impressive than when we actually dig deep into it. Because if you look at vaccinated versus control, the probability of having symptoms, you're really seeing, not a huge difference in the curves over time. And then if you actually break down the specific symptoms, they have figure 3 where they go through, fatigue, anosmia, headache, cough, and you're really comparing control to vaccinated. You're seeing some benefits, but they're just not as impressive, I think, as we would hope. So we'll leave links into those as well. All right. And then the last article, it closes out with this. The article, Neurological Post-COVID Syndrome is associated with substantial impairment of verbal, short-term, and working memory, published in Scientific Reports. So in this study, the investigators performed these in-depth neuropsychological assessments of post-COVID syndrome patients, referred to the neurological PCS clinic, compared to patients without sequelae and healthy controls. Really what this is kind of trying to decipher the most prevalent cognitive deficits, because we know they have deficits, right? They were referred to this clinic. And they do these detailed neuropsychological tests, a battery of tests looking at general orientation, motor and cognitive fatigue, screening of depressive anxiety symptoms, information processing speed, concentration, et cetera, et cetera. And they present all the data in a number of figures, but basically what they're again, as prior studies have done, they're documenting substantial impairment of verbal, short-term, and working memory in these folks. All right, I will wrap it up there before emails by saying, as we've been saying for years now, about 5 years now, no one is safe until everyone is safe. We are in the throes, the agonal throes of our Micro TV fundraiser. So January, this is our third and last month. We will double your donations. So if we excite your inner scientist, Vincent?
That's right.
Or we keep you safe, then go to parasiteswithoutborders.com, click donate, and thank you for all the folks that have already done so.
It's time for your questions for Daniel. You can send yours to daniel@microbe.tv. Judith writes, I received a heart transplant 20 years ago and take tacrolimus and mycophenolate, mofetil, to prevent rejection. I'm 76 years old, otherwise healthy and active. I've had COVID once, treated with remdesivir, recovered completely, up to date on all vaccines, including the latest booster in September. When I requested PEMGARDA from my primary care physician, she checked with the infectious disease docs in my health plan. The ID physician recommended vaccinations over the PEMGARDA infusion due to the risks of side effects, potential harm with the infusion. Is PEMGARDA really this high risk? In my case, do you think the benefits outweigh the risk?
Yeah, Judith, my advice in this kind of a scenario would probably be a bit different, right? So you're on the tacrolimus, you're in the mycophenolate. These are, in large part going to impact the T cell response, right? So they're helping prevent rejection. And 20 years, that's fantastic. So keep going. Keep with your vaccination, right? So you want to get your vaccine. At this point, we're recommending for someone who would be high risk like you twice a year, so every 6 months. But there's no reason in my mind why you wouldn't add PEMGARDA on top of that. I mean, you're profoundly immunocompromised. You would meet criteria. And PEMGARDA is not really high risk. We did see reactions about 1 in 1,000, but the PEMGARDA, about a 70% reduction in people even getting symptomatic COVID on top of all the other things we're doing. So makes a lot of sense. It's a every 3 month treatment. And so I would sort of revisit that.
Connie writes, I would like to know your take on whether an avian flu pandemic here in the U.S. would have the 30 to 50% mortality rate I've heard about. That seems unimaginable. Could it really be that high? I'm wondering also whether we have any effective antivirals against HIV-N1, similar to the great effectiveness of Paxlovid for COVID.
Yes, this is a great question. I think it circles us back to the discussion we had the last couple episodes where we talked about the fact that there are different types of avian influenza, right? So there's the bovine, the type B, which really has resulted in mild disease, conjunctivitis, Now, there's also the type D, the clade D. The clade D can be deadly. It is this 30 to 50% mortality. It tends to so far be a direct avian to human transmission. We have not seen any human or other types of transmission outside of that scenario. That does have a high mortality rate, but that's the one that I would say keeps people up at night, because if there is this transmission, if we see more people infected with the clade D H5N1, that's the historic mortality that we've seen. Now, the next is, what about great effectiveness? Well, we talked a little bit about antivirals earlier. So that was things like oseltamivir, so Tamiflu, Xofluza. And those are actually effective against the H5N1 viruses. So we would hope that if treatment is initiated within the first 48 hours, that we could see a benefit. And I think while we're talking about flu, I should say, what do we do when someone's sick enough that they end up in the hospital? So hospitalized patients, we have a tremendous amount of data on oseltamivir, Xofluza, baloxavir. We don't really have enough in-hospital data, so we tend not to use that in hospitalized patients. But if we started to have issues with H5N1, I would want those studies being done as well, maybe even dual therapy.
As far as pathogenicity goes, there's no reason to assume that the high mortality would occur if H5N1 became human-to-human transmissible, right? There's no reason to assume that. We're looking at spillovers from birds to humans, high mortality. It could be that if it transmits among people, it's no flu, no seasonal pandemic. Human flu has been that high mortality rate, so I don't see why it should be the same. It shouldn't be the same, right? So I don't worry too much about that.
Yeah, I guess that's a challenge. We don't know what it's unknown. We don't know what the mortality rate would be if there is human-to-human H5N1. What modifications to the virus would be required for that, and what would their impact on mortalities?
I mean, the only thing I can say is that if you infect ferrets with H5N1, it's lethal, but it doesn't transmit among ferrets, right? If you make changes in the virus so that it can now transmit, it's no longer lethal. So,
yeah, that whole weird gain of loss of function at the same time.
Yes.
Right? So, yeah.
Jason writes, have there been any drug trials using Paxlovid and Lagevrio, molnupiravir, in combination to treat COVID, and what did they show? If not, don't you think that would be a good idea?
Yeah, so there've been a few studies, we've talked about them, where combination therapy was used. And one of the comments, right, is you're going to see less of the mutational signature of molnupiravir if you're also shutting down, the protease with Paxlovid. People seem to do fine in those studies. That's an interesting issue. Is there still a place for those studies going forward? We'll have to see.
David writes, I listened to TWiV last week. I'm a retired allergist. It is not uncommon to have a non-itchy rash if someone is suffering a viral infection and receiving a beta-lactam antibiotic. The majority of the people with a non-pruritic rash will not be truly penicillin allergic. For the patient that you discussed this week with potential penicillin allergy, I would recommend the patient see an allergist. Allergy testing should be able to rule this in or out fairly quickly with a high level of accuracy.
Yeah, I think that's excellent. And always great advice. Having a penicillin allergy on your record is not a benign thing. You end up getting inferior medications, particularly when you come through the ER. I should throw everyone under the bus. Whether you're on the floor, whether you're in the ER, docs tend to shy away. They tend, particularly right now that we're having all these issues with invasive strep, and we're giving people macrolides, which don't work 30% of the time. If someone tries to give you a penicillin allergy label, it is worth your time to go see an immunologist, get that testing done, and really clarify.
And finally, Lori writes, I saw a newsletter that states there are reports from China of a newly virulent mutation of an old virus, the human metapneumovirus. According to the newsletter, hospitals are being overwhelmed and mass graves are appearing. I've not heard anything from any other source, And the writer does admit that it's difficult to confirm the truth of this because of China's censorship. So I came to the best source I know, TWiV. Is this bogus?
From everything we know, yes, this is bogus. So we talked about this because I was asked to be on one of these shows. It was like the O'Reilly show or something, and it was what's going on in China. We're seeing social media with these overwhelmed hospitals. So China right now, like the U.S., is having a surge in winter respiratory pathogens. Like the U.S., it's mainly influenza A. There's some metapneumovirus, but it's not a huge amount. Some of these headlines can be misleading. I saw this one headline, human metapneumovirus is surging. Numbers have doubled in the last week, up to 2%. That's not fair. 2% of respiratory, hospitalizations. That doesn't count as a surge. So unfortunately, WHO has investigated this. They basically said no smoke, no fire. This is just sort of a little bit of a social media storm, but we'll keep an eye on it. But yeah, so far there doesn't look there's any credibility to these headlines.
That's TWiV Weekly Clinical Update with Dr. Daniel Griffin. Thank you, Daniel.
Oh, thank you. And everyone, be safe.